Hi, so today's 2 minute topic is going to be cholesterol embolism and cholesterol emboli. So we are looking at it from a renal point of view, and that is the most commonly tested on test day. So let's speak about it. All right, first of all, out here we are looking at this particular artery that kind of has a cholesterol emboli right here. All right, and this cholesterol emboli, if we can see during particular procedures like probably stenting or endovascular procedure, leads to its dislodgement, and it somehow reaches to the renal artery. All right, this is the renal artery, and left renal artery. So it's basically entering the renal artery, and from here the entire series of complications begin because the blood flow to the renal is kind of cut. So what are the causes of it? The causes are simple. First of all, we need to understand that endovascular surgeries and interventions, as demonstrated in the particular image or diagram up here, is the most common cause. Then we also have heparin induced thrombocytopenia, which is your HIT. All right, heparin induced. So actually it causes a lot of clotting and kind of embolies. So HITs, when we give heparin to our patient, commonly seen. It could also be spontaneous, obviously, and it could be because of a stent or another procedure, as basically endovascular surgery or intervention that covers. Now, clinical features, if we speak about it, let's just kind of cover the clinical features here itself. The first clinical feature that you should understand is that because there's no blood flow and the blood is literally being diverted to the right kidney, and here the blood is kind of decreased. First of all, you'll see a lot of hypertension. You will see decrease. In case the right kidney is compensating, you'll see a lot of hypertension. You will also see a certain amount of oliguria. You might just see a little bit of renal failure in case the right kidney also kind of is not able to take over the role. Number one. Number two is when these cholesterol emboli go and dislodge somewhere else, let's say in the foot. All right, in the foot, they actually lead to something called as a livedo reticularis, and that's something that you should understand, livedo reticularis. And third is that when it kind of reaches to the eye, it can actually cause lesions in the retina, and in the retina they cause retinal plaques called as Hollenhorst plaques. We'll see those particular pictures after some time. So those are the kind of complaints that we have. All right, and clinical feature is going to be your pre-renal azotemia in case cholesterol emboli is bilateral. If unilateral, obviously you can see one side compensating and might not be able to show any kind of features. Talking about what are the diagnostic markers, the first thing that you should remember, and I want everyone to remember, is eosinophilia. It's not, I cannot stress how important eosinophilia is because it's so transient and it's so specific to cholesterol embolism that transient eosinophilia is something that comes up on test day. C3 levels are low and LDH levels are high, obviously because of hemolysis. Biopsy is when you do a particular biopsy of the kidney in particular, you see biconvex, bifringent cholesterol crystals, and this is basically what we have as your livedo reticularis. If you look at the particular leg, it is kind of bluish in pattern. So livedo reticularis is basically this. Another drug that can lead to livedo reticularis is amantadine. You should keep that in mind. It is given in Parkinsonism. And another important thing that we should speak about out here is these drusen's that we have. Okay, these are called your cholesterol emboli, which is called nothing but your Hollenhorst plaques. And that is about it for 2 minutes video on cholesterol emboli.